Transfemoral TAVR is often managed with general anesthesia. However, a simplified percutaneous approach using local anesthesia is the subject of a discussion in JACC Cardiovascular Interventions, and it's on feasibility and 30-day outcomes of exclusively local anesthesia and fluoroscopic guidance. And Dr. Cribier, who is a co-author of this paper, can you tell me a little bit about the study and what your approach is in this one?
Well, actually, just to start with, I have developed this technology of TAVI 10 years ago for patients who could not sustain cardiac surgery, but also very often because of contraindication to general anesthesia. So it means that the first patients was done under local anesthesia, and all the next patients, who are all compassionate, were done in my department under local anesthesia because of the risk involved by general anesthesia. And it was working so well that we have been continuing all the time, since the very first patients, to do all the femoral approaches under local anesthesia and sedation without any general anesthesia because of the additional risk that is involved by putting the patients under general anesthesia, and especially the lack of stability of the aortic pressure. So I think that it was quite important to publish the results of our series because today we have been doing probably more than 350 patients under local anesthesia. I have been trying to convince that local anesthesia and sedation was a better strategy for the patients, especially today that we have small sizes devices. You know that in Europe we are using the Sapien XT valve, which is smaller than the Edwards Sapien used in the United States. And so I think that it was a real good time to share the experience of local anesthesia sedation for the patients, especially in Europe. And well, the results are quite interesting because we did compare our results. We have 150 patients, more or less, done with local anesthesia and sedation alone, including all the patients with the Edwards Sapien and cut down of the femoral artery. And we did compare these results with the results generally obtained in the literature with patients undergoing the same procedure under general anesthesia, and we were absolutely unable to see any difference. So it means that you can absolutely safely apply this TAVI procedure using local anesthesia, and more with the Sapien XT, because now we are using the percutaneous approach and the closing devices, like, for example, the ProStar XL 10 French. It works beautifully well. The patient do not feel anything. Of course, we can have an anesthesiologist in the room because it's important to be able to control, the hemodynamics and the patient in general during the procedure. But general anesthesia is not used at all. Well, now, one of the big arguments to give general anesthesia instead of sedation in those patients is that many investigators want to do the procedure under online transesophageal echocardiography. So if you place a probe for doing a TEE during TAVI, then you need to give general anesthesia for patients because they cannot stay more than 1 hour with the tube in the throat, But my personal feeling is that transesophageal echo for the TAVI procedure is not that crucial at all. And we can prove it in this paper because we have been never using transesophageal echo. And again, the results are absolutely similar to the results generally observed in the literature. Actually, when we say conscious sedation, it means, of course, a very strict local anesthesia. So we are giving a lot of lidocaine, just for the patient not to feel any pain. The drugs that we are giving includes morphine-like drug that we call in France nalbuphine, and we also give midazolam, which is a very known drug for anti-stress. And if you put all of that together, the patients feel absolutely no pain.
Wow. And it could be some really helpful for the patient as well as for the doctor.
Absolutely. Because of this strategy, first of all, the patients can be discharged after 3 days. In my department, they stay between 12 hours and 24 hours in intensive care units. Then they are transferred into the ward, and then they are discharged after sometimes 2 days or even 3 days without any problem. So I think for the patients, it makes a big difference. Also, we have many patients with pulmonary insufficiency. This is part of the risk factor which is associated in the contraindication of surgery. And of course, if you don't give general anesthesia, you don't have this problem of extubating, which can be really an issue for the patients. So all of that disappears, and we are extremely satisfied. I must say that more and more we have been convincing a lot of teams in Europe to use this strategy, which is really excellent for the investigator, the technique per se, and the patients.
So please read the article, JACC Cardiovascular Interventions, Cribier and Colleagues. I'm Rick McGuire.